We are continuing our vaccine series in this time when vaccines and public health in general are under assault. We still believe in evidence-based medicine, and here we are talking about it. So I'm going to give the rest of the time to Dr. Jennifer Mbuthia to tell us about the pertussis vaccine and have some time to answer questions at the last minute. As usual, I will take a peek at the chat. If there's any kind of clarifying questions, I will interrupt. Otherwise, we'll have questions at the end. I'm looking forward to learning with you. Go ahead.
All right, thank you so much. So these are the learning objectives, and we will dive right into it. First, talking a bit about pertussis, the disease. It is an infection caused by Bordetella pertussis. Common names are either whooping cough or the 100-day cough. And this bacteria is a gram-negative toxin producing bacteria that can be found in the oropharyngeal area. And the toxins made by this bacteria paralyze cilia. It causes an inflammatory response in the respiratory tract that can interfere with clearing of pulmonary secretions. This is an airborne infection, and humans are the only known reservoir. So it's person-to-person transmission via respiratory droplets or by contact with respiratory secretions. And most commonly, older school-age children, including teenagers or adolescents, and adults tend to be an important reservoir for spreading Bordetella pertussis. So with this infection, it's the toxins that are the real danger, not the bacteria itself. So there's multiple toxins that the bacteria produce. And many of them are antigenic and biologically active. So it's not just the pertussis toxin itself. There's a hemagglutinin, adenylate cyclase, and essentially all of these different toxins create a bit of chaos in the airway. They can cause some small-scale ischemic necrosis. They interfere with phagocytosis of the bacteria. They paralyze the cilia itself, and so that decreases the ability to just do the physical clearance. But that kind of chaos in the airway not only interferes with the host immune system's ability to take care of the infection itself, but leads to the different stages of a pertussis infection and why it oftentimes will have several weeks to months of ongoing symptoms, even after the infection itself has been cleared. So there are several different stages of pertussis. The incubation period is usually 7 to 10 days, although it can range between as little as 4 and as many as 21 days. But the first stage is the catarrhal stage. So it oftentimes has a similar presentation to a common cold or upper respiratory infection. Starts off with some runny nose, sneezing, low-grade fever, and the kind of a mild cough that you would expect with a common cold. And then what happens is that cough will gradually become more severe. But the catarrhal stage is generally lasting for 1 to 2 weeks. Then you have the paroxysmal stage. And this is where the cough is the most dominant and driving symptom. The cough is more severe, and then patients will experience these paroxysms with numerous rapid coughs in a row with kind of this inspiratory gasp or whoop, hence the name whooping cough. That is most often when the diagnosis is suspected and made. And the paroxysms occur more often in the evening or at nighttime, but patients can become cyanotic. Young children and infants can become very ill and experience a lot of respiratory distress during this stage. Post-tussive emesis is kind of a classic part of the paroxysmal stage. And if anybody has just had a bad cough, exhaustion is part of what happens when you're coughing a lot. We'll now have these paroxysms where basically you have to gasp to get air in. So exhaustion, dehydration can occur. Now, in between the paroxysms, the patient may not appear very ill. But then when they have these paroxysms, they're usually very, very sick. And so one of my mentors in pediatrics is a pediatric pulmonologist. And I just remember from when I was a resident, he said, there's 2 things in kids that cause post-tussive emesis. And he goes, so if you got post-tussive emesis in a kid, you need to think of pertussis and you need to think of asthma. And interestingly, one of my my allergy fellowship colleagues who had also trained under that same pediatric pulmonologist, he had done a survey and published it for patients referred to allergy immunology for asthma. And statistically, he found a significant number were reporting post-tussive emesis with their asthma. And I still hold that in my heart when I see patients referred and there's a report of coughing so hard that they throw up. And two things that I want to make sure I ask questions about tied to both pertussis as well as asthma. Then you've got the final stage, the convalescent stage, and this is gradual recovery. This can last for a few weeks to a couple of months. And one of the things about the convalescent stage is that if someone were to just get a mild upper respiratory infection during that stage, the paroxysms can recur. Hence, the 100-day cough. This has been a stage during which I have received not necessarily pediatric, but adult referrals. And there have been several cases in the last probably 3 years where essentially based off of the time frame and the recurrence of these paroxysms in adults, it's presumed that they actually had contracted pertussis. So this is just a summary slide that shows from initial incubation period through those 3 stages of pertussis, but then most importantly is that window of time where they are considered contagious, the communicable period. So the onset is usually about 3 weeks for that window, starting during that first catarrhal stage and then going through usually the first 1 to 2 weeks of the paroxysmal stage. So pertussis in older age groups, and I include adolescents in this age group, it's an important thing to be aware of because even if someone was previously fully vaccinated during their childhood, early childhood and infancy, while they may have a milder disease of pertussis, they are an important vehicle of spread in communities. They can still transmit the disease to other susceptible people, including unimmunized or incompletely immunized infants. And like I said, by the time pertussis is suspected in an infant, most of the time that infection actually was introduced into the household by other older household contacts. So just a few other things to consider in the differential. Again, croup, things like bronchiolitis, other URIs, even bacterial tracheitis, foreign body aspiration, especially with those kind of sudden onset paroxysms. In small infants, we also consider GERD as something. And then some of the things to also take into consideration, depending on the age of the patient, would be things like COPD, cystic fibrosis, asthma, TB, or some sort of congenital anomaly. So it's important to keep pertussis on the differential as well, but it's a pretty broad differential to have with patients who are coming in with these chronic and severe episodes of cough. So some complications of pertussis, the most common cause of pertussis-related deaths is secondary bacterial pneumonia. So when you cause chaos in the airway and the ability of immune cells to come to the airway to fight infection, and also the ability of the airway to clear infections, you are setting up the perfect petri dish for bacterial pneumonia to come in. There can also be neurologic complications such as seizures and encephalopathy. Most of that is due to hypoxia from these coughing paroxysms and coughing fits. Other complications are a result of the pressure effects of these severe and strong episodes of coughing. So pneumothorax, epistaxis, rib fracture, syncope, urinary incontinence, in particular in adolescents and adults, and then also weight loss because you can't eat if you're coughing. You can't maintain calorie less than 6 months old who had pertussis disease did require hospitalization, and that's based on 2024 data. So this is not an insignificant condition when it pertains to infants. According to CDC data, there were 16 deaths due to pertussis infection in the year 2025. Again, this is not something that we like to see, especially when we do have a vaccine and vaccine programs and plans and recommendations that apply not only to infants, but also to pregnant patients during that third trimester, which leads into a discussion about the vaccine itself. So a little bit about the history of the pertussis vaccine, because the vaccine that is currently licensed and used in the US has not always been what we had. So the pertussis vaccine was actually developed in the 1930s, and it was a whole cell inactivated vaccine. So they inactivate the bacteria. And then in the 1940s, it was combined with diphtheria and tetanus and eventually licensed as the DTP vaccine. So in the 1960s, that's when many US laws then were passed in most states requiring immunization of children with DTP prior as part of a mandate for entering schools. And that seemed to be going fairly well. And then in the early 1990s, due to some issues that I'll talk about on the next slide, the acellular version of the vaccine was licensed, and that's what we call DTaP. In 1996, the Advisory Committee on Immunization Practices, or ACIP, placed recommendations that DTaP actually be utilized as the only pertussis-containing vaccine for all infants. And then in 2005, Tdap was approved for use as a booster in teens and also adults. In 2006, ACIP recommended all 11 and 12-year-olds and adults receive a booster of Tdap. And then in 2011, the recommendation came about for Tdap with each pregnancy for that pertussis protection. So there were some controversies that happened in the 1970s and 1980s that led to the change from DTP to DTaP. And there were concerns that the whole cell pertussis vaccine was triggering adverse events, specifically prolonged crying, febrile seizures, these episodes of hypotonic hyporesponsiveness in infants who were receiving the vaccine. And then there were also claims of links to other neurologic issues like encephalopathy. So the whole cell pertussis vaccine was being blamed for a variety of things, and that continued to evolve to be the blame for intellectual and physical disabilities. And then in 1982, there was a documentary called DPT Vaccine Roulette. And within that documentary, it showed children and young adults with disabilities, and the families attributed all the disabilities that their child was suffering from on the DTP vaccine. So in the 1980s, then there was an increase in lawsuits against vaccine manufacturers, specifically ones that made DPT vaccines. So lawsuits filed, and that leads to not only increases in what manufacturers were charging to make the vaccine to cover their malpractice or whatever the equivalent is for pharmaceutical companies, but also there were providers who were decreasing what they were purchasing because of the rising cost. They had families that were decreasing the request or were refusing to receive the DPT vaccine. And then over time, fewer companies were making the vaccine. So that is what led to the 1986 National Childhood Vaccine Injury Act, the no-fault system to compensate for vaccine injured patients. It also is what led to the development of the acellular product of the vaccine. Now, the whole cell pertussis vaccine does still get manufactured in the globe. And so there are countries that do still use it, but within the United States, the acellular vaccine is the only one licensed for administration in the US. So a comparison of the two vaccines. So we have DTaP and Tdap, versus DTP, DPT. So the acellular version, it just contains the purified components of the Bordetella pertussis bacteria and toxins. It is less reactogenic, which means there will be fewer side effects. It is a bit more expensive to produce, but it's all that we have available in the US and also in many high income earning countries. The downside of acellular pertussis vaccine, though, is that immunity will wane faster than the whole cell vaccine. Whole cell pertussis contains the entire killed organism, but it is more reactogenic. And so it is still available in some low to middle income countries. And in some of those countries, their Ministry of Health has guidelines for who can get an acellular product. So they will have both products available, but because of cost and supply, the acellular product is reserved for special circumstances. But one of the things about the whole cell vaccine is that the immunity doesn't wane as fast, but also because it's using the entire organism, it actually is more effective at preventing disease transmission than the acellular vaccine. And unfortunately, I do not see the US going back to a whole cell version of a pertussis vaccine. However, by going to the acellular version, there were a few things that got sacrificed in the name of patient safety and broader patient and parent acceptance in our country. So the acellular vaccine has up to 5 bacterial antigen components in it. It also does have an adjuvant. It has an aluminum adjuvant to boost the immune response. And then there's stabilizers and other substances like polysorbate and some trace antibiotics in it that are part of the manufacturing of it. But the toxin is what causes the airway damage. And so the acellular vaccine has antigens for the toxins. So the bacteria itself is not the target of vaccine-induced immunity. So while the whole cell version would also target the bacteria, the acellular version really focuses on the toxins. So in terms of vaccine efficacy, so after the initial 3 doses of DTaP in infants, vaccine efficacy is somewhere between 80 to 85%. Young children who get all 5 doses on schedule, they'll have full protection against severe disease in about 98% of the children within the year following that last dose. And then 5 years after getting the last dose, the VE does decline down to about 71%. Tdap, the one for older children and adults, fully protects about 73% of adolescents within the first year after vaccination, and that assumes that they had received a full infant series. And then that wanes down fairly quickly to about 34% vaccine efficacy about 4 years after that vaccine booster has been given. So acellular pertussis vaccine efficacy in pregnancy. So this is where the recommendation is made for every pregnancy. So during the 3rd trimester, the vaccinations that are recommended are really to capitalize on maternal IgG production and transplacental transfer to the developing fetus. Excuse me. Ooh. So essentially, during the final trimester of pregnancy, what happens is there's a lot of what I call fattening that happens. There's iron stores that are transferred to the developing fetus. Fat stores are built up, but also IgG is actively pulled across the placenta and transferred to that developing fetus. So that is where you maximize on that active transfer by providing certain vaccines during that 3rd trimester. So 1 dose of Tdap during that 3rd trimester of pregnancy, and that's between 27 and 36 weeks gestation, will prevent about 78% of pertussis cases in infants less than 2 months of age, and about 90% of hospitalizations for infants less than 2 months of age who do end up contracting pertussis. So this is passive immune protection that really is focused on the benefit to that to the newborn. For obvious reasons, there may be issues where, the baby's delivered too soon after vaccine. So the maternal immune system didn't have enough time to make lots of IgG to then transfer prior to delivery. It kind of overlaps with what we see with the RSV vaccine given during pregnancy. You need to give the maternal immune system about 14 days to really maximize its antibody production to then really have that big push. However, when administered with each pregnancy, you do see a significant impact in that passive protection of the newborn. One of the things too that was identified with regards to pertussis protection was that back in 2010, 2011, there was an outbreak of pertussis in California, and the majority of these cases were happening in children between the ages of 8 to 12 who had only received the acellular series during their infancy and toddler years. So through Kaiser, there was a case control study done that evaluated the risk of having pertussis based off of time since that 5th dose of DTaP. And what they found is, kind of you decrease from that 95% down to 71% 5 years after the 5th dose. And then it will continue to decline for each year after the 5th dose. Teens who had received 4 doses of DTaP as infants were 6 times more likely to be PCR positive for pertussis than those that received the whole cell DTP vaccine as infants. But this outbreak in California really demonstrated that how quickly the protection with even being fully vaccinated declined with regards to the acellular vaccine. I was a general pediatrician in Germany from 2003 to 2006, and in the late 2005 and then into early 2006, we actually had an outbreak of pertussis cases among the military bases in the city where I was stationed. And it started with early high school age children that were all, obviously attending school together. Then it spread during church events that were happening on the Air Force Base. And before too long, I got to learn a lot about how scary pertussis is in very young infants when they get it. So when it comes to pertussis, who should be vaccinated? Necessarily with the same product or with the same interval. So adults need a booster every 10 years for tetanus and diphtheria, and you can do either TD or Tdap, but healthcare workers, you should always opt for the Tdap vaccine for that boost of pertussis protection. Adolescents should get their Tdap booster around 11 to 12 years of age. And in particular, when pertussis cases are on the rise, if somebody has a need for a tetanus boost, let's say they have a wound, they had a dog bite or something, if you know you have a fairly decent number of pertussis cases in your community, you should always be offering the pertussis containing booster, even though what you're administering the vaccine booster for is tetanus protection, the added pertussis protection will be value add for that community. And then to protect infants, especially newborn infants, cocooning strategy is also encouraged. So anybody who's going to have a lot of contact with that infant, including infant caregivers, potentially grandparents, you can recommend that they get a recent dose of pertussis vaccine. So not the same, so for every grandchild, they don't need to get a pertussis booster the way that every pregnancy needs the booster, but you want to double check and see when the last time was that they actually had a pertussis containing vaccine, and knowing that you've got a pretty significant wane in protection around that 4 to 5 year mark. Just something to consider offering or recommending for people who are going to have a lot of caretaking, a big caretaking role in that infant. So in terms of any contraindications or precautions, so this is pretty much universal for all vaccines, but a history of anaphylaxis to a dose of a previous pertussis-containing vaccine or vaccine component. It's important, though, that if a patient does have a history of anaphylaxis to any vaccine, that they should be referred for an evaluation by an allergist, because there still is a potential to achieve vaccination whether it is through a different agent or through some sort of a vaccine desensitization. Another cell vaccine to another identifiable cause that occurs within 7 days of vaccination with a pertussis containing vaccine. So again, it is connected to the concerns about encephalopathy that came up in the 1970s and 1980s. When it comes to issues of encephalopathy with the acellular vaccine, that really hasn't been seen. And even more interesting, in countries that do still use the whole cell vaccine, they don't really see an attributable risk of encephalopathy to the whole cell vaccine. But like I said, I don't think in the US we're ever going to go back to the whole cell vaccine. But it does raise a question of, did we truly need to change it? But the change was made in the interest of growing public trust. In terms of precautions, if someone has a moderate severe acute illness, they should maybe delay getting a vaccine. But another one, and it's tied to, again, the neurologic concerns, is if someone has a progressive or unstable neurologic disorder or has an uncontrolled seizure disorder or progressive encephalopathy, you want to delay vaccination until their condition has not only been fully evaluated, but also is stable. Any person with a history of Guillain-Barré syndrome within 6 weeks of a previous pertussis-containing vaccine, that is considered a precaution, not an absolute contraindication. And then another, probably one of the more common mislabelings of being vaccine exempt that is more of a precaution is if someone has an Arthus type reaction to previous doses. So an Arthus type reaction, it's a robust, large local reaction, and it can be, a grapefruit size amount of just swelling and redness. It is an immune reaction, but what can oftentimes happen is that it is misattributed to being an allergic reaction. It is not an allergic reaction, but because of that misattribution to being allergic, then the patient or parent will report that they are allergic to the vaccine, and somehow it evolves into it being a contraindication. But an Arthus type reaction is just a precaution, not an actual contraindication. In terms of what vaccines we have in the US, again, we've got DTaP and Tdap. Talking to a pediatric community, so you guys are very familiar with what vaccine is for what ages and also the number of doses per series if you're starting with DTaP versus Tdap. Now, the letters and it being capital or lowercase ties to the higher dose of the diphtheria and pertussis containing antigen in it. Now, something that can oftentimes get very, very complicated is catch-up schedules or incorrect vaccine administration. So there's plenty of clinical places or pharmacies that will have both DTaP and Tdap. So you can see where potential error can occur. But also you may have a patient who started on the vaccine series. There's been gaps. They didn't complete it during those infant years. So the number of doses and the product used and the age when they got it will determine what is next in the catch-up schedule. So there's 3 main age groups when you consider what step is next. So the first age group is the 4-month to 6-year babies or children, then 7 years to 9 years old. And then that third age group is 10 to 18 years of age. And the different catch-up schedule and what do they get next if they had 1 dose, 2 dose, 3 doses, and what the product was. There are algorithmic charts that you can find. The CDC does still have those charts. I did verify that. And they also do address like what happens if a DTaP is accidentally given when Tdap was due, versus if Tdap is given if DTaP was due. So again, DTaP has higher diphtheria and pertussis antigen versus Tdap. So giving more antigen when less was due, usually you wouldn't repeat the dose. But if the lesser antigen containing vaccine is given, then there is a likelihood that the dose has to be repeated with the proper vaccine, but then that also depends on how many previous doses they had received and the age of the patient. So it can get very complex and complicated. I would never recommend anybody try to memorize it, but instead know that there's a chart that can walk you through what to do based off your individual patient. Now, a little bit about vaccine pertussis cases, not only in the US, but also specifically in our state. So this is CDC data on pertussis cases in the year 2025, calendar year 2025. So between 2024 and 2025, within the US, the number of reported pertussis cases actually did decline. So that's great. There were fewer pertussis cases. But we did have 16 reported deaths in the US. 2/3 of them were infants less than 1 year of age. 6 of them, or about 1/3, were over the age of 1. This is the spread of reported pertussis cases, and then the percent that were hospitalized by age. So as you can see, infants less than 6 months old have the greatest risk of requiring hospitalization. 20 years and above is pretty much all adults. That's the next highest age group, but it encompasses quite a large number of patients in terms of age span. The vaccination status of pertussis cases is listed here. So for a significant number of cases, the vaccine history was unknown. But an important thing to kind of identify is that even those who completed at least 3 doses of the primary series at the time of the diagnosis of pertussis, it's still not a perfectly protective vaccine. Now, this is looking at not only the individual and their waning immunity, but also the role that this plays in how easy it is for pertussis to spread within communities. Now, a little bit about pertussis cases specifically in the state of Hawaii. So I broke it down by county, and then the Department of Health also has non-residents who were diagnosed with pertussis while they were here in Hawaii, but they don't reside here in Hawaii. So that's its own little line. So between 2024 and 2025, the number of cases here in Hawaii went up. Now, if you remember a few slides ago, nationally, pertussis cases declined in 2025, but not for us. They went up by quite a bit. And then I broke it down by, so you can see the numbers per county, the absolute numbers, but also the number of cases per 100,000 in the population. So even though the highest number, may be in, Honolulu County, percentage-wise, it's actually higher. There's higher rates of cases per 100,000 people living there on the outer islands. And something that I increasingly point out is that when you leave Oahu, in particular, when you leave Honolulu, that is rural medicine. So knowing that about 1/3 of infants with pertussis require hospitalization, the resources on those hospitals on the outer islands, it's very resource limited. And in particular, they don't have PICU beds. There's those of you who practice and do hospitalist medicine on the outer islands, you guys know this better than I do. But when you flip it to kind of that number of cases per 100,000, it really does emphasize the importance of continuing to provide education and finding ways to not only get people to be updated on their routine booster, but also to make sure that they are fully vaccinating their infants. This is a breakdown of cases. Again, this is in the 2025 data by age group. So again, the majority of cases per 100,000 persons in the state was mostly in those under 1 year of age. And it's not a coincidence that the vaccination rates for DTaP for children entering the school year in 2024 to 2025 had declined. Prior to COVID, it was a little over 95% compliance. And then 2024 to 2025 school year, it dropped down to a little over 91%. And that no shock, decrease in vaccine confidence over the last 5 to 6 years. So vaccination rates for children who are entering kindergarten has also declined. Increase in widespread vaccine misinformation, decreased trust in the ACIP recommendations and the CDC. And I mean, so many reasons why there's decreased vaccination rates within our state. Ultimately, the patient's healthcare provider is still considered the most trusted advisor for vaccines, which is why having opportunities to provide education to those who are primary care providers and are going to be receiving these questions, I feel like that is a force multiplier. So what do you do if you have a suspected case of pertussis? So a little bit about the actions to take. There's probable versus confirmed. In either case, you should contact the Department of Health before you don't wait for confirmation. So probable case classification is defined as in the absence of a more likely diagnosis, illness meeting the clinical criteria, or illness with cough of any duration and at least one of the other things. So that paroxysms of cough, inspiratory whoop, post-tussive emesis, apnea with or without cyanosis, or contact with a laboratory confirmed case of pertussis. And then the confirmed case is that there's been isolation of either Bordetella pertussis from a clinical specimen or they're PCR positive. Different kinds of ways to test for pertussis. So you've got PCR of the nasopharyngeal space. Again, I have memories of having to do this in our peds clinic in Germany, and we tried to separate anybody with cough from all of the other children there for well visits. It was an interesting exercise in the complications of logistics when you don't have two separate waiting areas. So you want to do the nasopharyngeal swab or an NP wash or aspirate in a viral transport medium. In suspected outbreaks, the PCR testing can be performed by state laboratory divisions with pre-approval from Department of Health. The turnaround time for the PCR is 48 hours. Then you've got culture, which actually requires growth of live bacteria. So the turnaround time for that is 7 days. Then you've got serologic testing, which you can consider doing, especially if a patient is in a later phase. So they've been having the cough now for more than 2 weeks, especially 3, 4, 5 weeks after the cough had started. You're less likely to have culture positive. You have diminishing return on PCR, but it could be another way to confirm that the patient actually did have a pertussis or a fairly recent pertussis infection. This is just a graphic to show the optimal timing for these different kinds of diagnostic tests. So PCR is probably going to be what the Department of Health is going to recommend because of the rapid turnaround time and the broader window where it is a useful test. Culture has a more narrow window and it takes longer to come back. And then serology is more of those later presenting cases. So a bit about medical management. Keep in mind, this is a toxin-mediated disease. So antibiotics will eradicate the organism and can decrease the spread and shorten the course of the disease. But once the toxin is out, antibiotics are not going to reverse toxin-mediated damage. So we do still recommend early treatment to lessen the severity of symptoms or the duration, particularly important with infants. And you want to treat kind of some of the following categories. Infants younger than a year, infants older than 12 months if it's within 3 weeks of cough onset, and then pregnant patients, especially if they're near term, within 6 weeks of cough onset. So you broaden the window where you're like, yeah, let's still give antibiotics in those cases. Like I said, the pertussis infection and the vaccine, neither one of them are really providing permanent long-term immunity. So even if somebody's like, yeah, I had pertussis last year, they tested me and positive. Hey, if they're due for a pertussis vaccine, you still want to vaccinate them. Unvaccinated or incompletely vaccinated people still need to complete the vaccine series, even if they have had pertussis. So if you come across an infant, they had pertussis at 4 months old, they still need to complete the series, both for the cellular immune memory from getting an injection of the vaccine, but also because you're not just trying to prevent pertussis, this is also building their immune memory for diphtheria as well as tetanus. In terms of close contacts, the secondary attack rate is about 80% among susceptible contacts. And so it's a fairly high rate of spread within, households. So antibiotics should be administered to all close contacts, regardless of their age or vaccine status. And this is one of those situations where vaccination status doesn't change the requirement for post-exposure prophylaxis. In a lot of other circumstances, like with measles, your vaccination status can impact whether or not you need to isolate and do all these, not when it comes to pertussis. So you still want to assess the vaccination status of close contacts because you want to provide additional counseling and let them know, how many more doses, make sure that they continue with their vaccine series. But the use of post-exposure prophylaxis in susceptible close contacts with antibiotics happens in all. So there's 3 macrolides that can be recommended for use by the CDC. If someone has a contraindication, such as anaphylaxis to macrolides, you can also use trimethoprim, sulfamethoxazole, or Bactrim. There is globally an increase in resistance to macrolides. So if we do get in a circumstance where we're identifying macrolide resistant bacteria, then that would be another indication to use Bactrim. Treatment after 3 weeks of symptom onset is unlikely to help, even if the person's still having coughing, except in those very special circumstances that I reviewed in the previous slide. Control and isolation. So this is current as of November 2025. And I put a little asterisk there because the Hawaii Department of Health is reviewing and plans to update their control and isolation recommendations. So when those new guidelines come out, that'll be distributed and disseminated, but be on the lookout. So 6 months from now, this may not be the most current, but persons with, cases, so people who have pertussis, especially if they're at the beginning of that catarrhal stage, up to about 3 weeks after the onset of the paroxysms, you want to make sure that they have received 5 full days of effective antimicrobial treatment. Persons should be excluded with pertussis, excluded from daycare, school, work until completion of 5 days of appropriate antimicrobial therapy. People who don't receive appropriate antibiotics should be excluded from school, daycare, work for 21 days after the onset of the cough. And then obviously hospitalized patients have to be put on droplet precautions. In terms of contacts, you want to exclude household contacts from public spaces. So that includes daycare, school, work, grocery stores until they've completed 5 days of prophylactic antibiotics, regardless of their vaccination status. Again, healthcare personnel, even, for asymptomatic healthcare personnel, regardless of vaccine status, who have had an exposure, you want them to receive post-exposure prophylaxis and then return to work after they've had 5 days. If someone does not receive post-exposure prophylaxis, you need to restrict their contacts from patient care and maybe offer telework as an option for 21 days after that last exposure. So there's a lot of impact that pertussis can have, not just on the close contacts, but also on healthcare personnel who've had a high-risk exposure to a positive case of pertussis. Anyone who becomes symptomatic, that's a little bit more straightforward because you're going to treat them and for 5 days of antibiotics, but they're also going to be excluded from work while they're still actively having their cough. In terms of notification, these are the notification numbers. Again, pertussis is a reportable disease. Don't wait for laboratory confirmation before contacting the Department of Health. Anybody who doesn't already receive the Department of Health medical advisories, here's a QR code that you can utilize to sign up to receive those medical advisories. And then that's my Queen's email. I actually literally just got a Department of Health email about 2 hours ago. It's been a work in progress, but I wasn't going to change the slides with that. But my Queen's email is also accessible. And what I'll do there is I will stop screen sharing and we'll hit do you want to hit the chat questions first or do the multiple choice questions?
Let's do the multiple choice questions quickly since we do have some time, but folks might need to drop off to go see patients. And that only takes a couple minutes. Thanks. Okay, I'm starting to see a few answers rolling in. But they're a little bit long questions, so I think we should give everybody at least another minute or two. So it's been about a minute and a half. Let's go to at least 3 minutes and then we can see where our numbers are at. And anyone who's done with their questions, feel free to drop any other questions you have for Dr. Mbuthia in the chat.
Okay, I'll close the poll. We're at the 3 minutes.
Anybody who wants another moment, unmute yourself now or forever hold your peace. I think we're up to 15, which is 60%. So yeah, sounds good. There was definitely quite a lot of spread on the questions. So, oh, whoops, I just, I clicked share the same time you did. So click again. I won't touch it. But perhaps Dr. Mbuthia, you can just clarify. I think some people were maybe tricked by DTaP versus TDAP and things like that in some of the questions. So maybe just let us know what the right answer is and why.
Yes, yeah. Okay, so the first question, 28-year-old pregnant patient, currently 35 weeks. Last Tdap booster was during previous pregnancy. That was 3 years ago. What's the most appropriate recommendation? So the correct answer is to administer another Tdap booster today or soon to maximize that transplacental transfer. So DTaP is not what you would give to an adult. So that's the reason why I think the second option is incorrect. Question number two, a 10-year-old boy presents with persistent cough that's lasted for 3 weeks, Cough is sudden, forceful, bouts, high-pitched inspiratory sound. Immunizations are up to date. Laboratory testing confirms Bordetella pertussis. So what's the primary reason this 10-year-old fully vaccinated child developed pertussis? And the correct answer is the natural waning of immunity provided by the acellular vaccine. So there wasn't antigenic shift or drift or mutations that occurred. Not to say that that can't happen. I hope it doesn't. And it also isn't primary vaccine failure due to poor manufacturing. We know that natural immunity or vaccine immunity is going to wane fairly quickly. Question number 3, an 8-week-old infant is diagnosed with pertussis and hospitalized for respiratory distress. The infant's 34-year-old father has a mild nagging cough, but no other symptoms. Which is the most appropriate management for the father? The answer is the first option, administration of a macrolide antibiotic, regardless of his vaccination status. So in that situation, you have a household contact who is symptomatic, a household contact of a confirmed case. So you would administer post-exposure prophylaxis. Question number 4, 6-week-old infant is admitted to the hospital with paroxysmal coughing and post-tussive emesis. PCR testing confirms Bordetella pertussis. The infant lives with his parents and a 5-year-old sister who has completed her DTaP series a year ago at age 4. So what's the management for the sister? So this is a fully vaccinated child who is a close contact with a confirmed case. So you still administer 5 days of post-exposure prophylaxis. So the fact that she's fully vaccinated, completed the vaccine series a year ago, you still treat. And one of the reasons so that question in particular, I thought was going to be a really important one to touch upon, because I'm sure you guys have come across or will come across that circumstance. And you know that the vaccine efficacy during that first year is really great, but the vaccine is against the toxin, not the bacteria. So the concern when you have post-exposure prophylaxis is that that patient, while they may not be symptomatic, could still have colonization with the bacteria because they are a close household contact of a confirmed patient. Therefore, in order to mitigate spread, you need to kill the bacteria. The only way to kill the bacteria is with antibiotics. But the individual child, the vaccine will protect her from having symptomatic disease, but not necessarily from getting an asymptomatic infection.
That actually brings up something you mentioned about cocooning. Uh, you mentioned in passing that it's recommended, and I was curious about that because I always thought that was the case, and I recently listened to one of the PHM from Pittsburgh's series on vaccine preventable diseases, and they did one on pertussis, and they actually said that cocooning wasn't really helpful for exactly that reason, and then mentioned specifically that this vaccine is not very good at inducing IgA immunity, and that therefore it's easy for the infection to be transmitted even if you don't have symptoms. So is cocooning just like maybe it'll be helpful and it definitely can't hurt, or is that kind of the rationale for recommending it?
Essentially, yes. So really the important part is all of the people who are going to be in close contact with the infant. Well, one, if anybody has any kind of illness, you hope that they're distancing themselves from the patient. And one of the challenges is, well, could you have asymptomatic infection? The likelihood of it being completely asymptomatic is a little bit lower. But you want to at least provide as much kind of protection from spread as possible. Obviously, there's going to be some household context, like, so let's say mom, she got vaccinated during pregnancy. The primary reason is to protect the infant with passive immunization or passive immune transfer. The dad lives in the same household. So if you can minimize his chances of having severe prolonged coughing as much as you can, because he can't necessarily, it's not like a caregiver who can just stay home for the day and call out sick. You maximize that. If grandparents are going to be staying at the house, you are also maximizing the likelihood that they're not going to have these severe bouts of coughing and potentially spread it even further. So even if they come into the house, now if someone has like a little bit of a runny nose, they should always be masking around a newborn infant. But one of the things is that a recently vaccinated person, while they can still have the bacteria in their body and they don't get IgA or a big IgA immune response, there's still the studies that have been done and targeted with intentional infection of animals. There is still a difference in how severe the symptoms are, and knowing that this is a droplet transmitted issue, if you're not having paroxysms of cough, then the logic is you're not spreading it as much or as fiercely and as forcefully. So I still find that the cocooning recommendation is still going to be helpful for that element, but you don't want to give people a false sense of security that then if they have tickle in their throat and a runny nose, that it's still okay for them to be cuddly cozy with a newborn infant. Any kind of upper respiratory symptoms should be taken very seriously around a newly born, but are you decreasing how much of a chance of spread in the household by making sure that they're current? And by current, it doesn't mean that they get, again, the vaccine with every pregnancy. It means that they've had a recent, they're at least within the 10-year window. So if grandma got vaccinated 8 years ago and she catches pertussis, she'll be symptomatic. It's not going to be veiled. The concern about the vaccine veiling a pertussis infection happens in those more recent years, meaning 4 years or less since their most recent pertussis vaccine. But it's an issue where, I mean, I was on the work group for with the CDC looking at the prevention of newborn pertussis. So, we looked at the data, we looked at cocooning, and there is still some benefit in cocooning. Granted, that was in 2010. I feel like now it's only become a little bit worse in terms of community spread. But it's still, I would still recommend it, but make sure people know if you don't feel well, put on a mask if you can't avoid contact with the baby.
Yeah, thank you. We have a couple minutes left. There's a question about DOH, basically contact tracing. So the Department of Health, do they call, send letter? What do they do?
So I believe for the close contacts of like household contacts, I believe they are still using telephone. So I don't work in the section that does contact tracing, but I believe it's still telephones. When it comes to like an airline exposure, that's where people will most likely receive a letter. But household contacts, work contacts, school contacts, they try to talk to, especially people who are still in the state. They're going to contact them in person to kind of explain to them where they need to go, what they need to do, make sure that they understand what's being explained to them and know where to go. And also then they have someone to loop back to with results.
Thank you. Okay, any last questions, folks? Drop them in the chat or unmute yourselves real quick if you want to. We've got 1 minute left. Okay, well then I will just say thank you for another great talk. We know to have high expectations and you always meet them. So thank you for educating us. And oh, there is one question about the increase. Well, I think in large part it's because of people getting more and more skittish about vaccines. I don't know if there's any other reason.
Yeah. We've got a significant decline in childhood vaccines in the state.
Yeah. Sadly, we're continuing to work on it. So thanks for a great talk. Thank you to all our participants for your enthusiasm, and we look forward to seeing you all in a couple of weeks.
Yeah.
Okay, thanks. Bye.